the first TA webinar related to the new federal maternal, infant, and early childhood home visiting program. My name is Lauren Suplee, and I'm the Federal Project Officer on the contract that's providing this technical assistance. And today's presenters include Dr. Robert Ammerman, Kathy Hatfield and Rebecca Kelly from Child and Family Tennessee, and Jill Filene from James Bell Associates. Unfortunately, Audrey Yowell was called away and is unable to join us today. This is as I said, this is the first webinar in a series of webinars for the DOHVE project, and DOHVE stands for Design Options for Maternal, Infant, and Early Childhood Home Visiting Evaluation. The contract has three main purposes. The first is to design options for the federal evaluation of the evidence-based home visiting programs noted in the legislation. Second, they're providing evaluation-related technical assistance for the promising approaches, also as mentioned in the legislation. And finally, they're providing technical assistance for grantees' continuous quality improvement, management information systems, and benchmarks. The team of this project includes James Bell Associates, MDRC, and a host of outstanding consultants, including Johns Hopkins University and Cincinnati Children's Hospital Medical Center and Every Child Succeeds. We are extremely excited today to share their work, and now I will turn it over to Dr. Robert Ammerman from Cincinnati Children's Hospital Medical Center and Every Child Succeeds.
Thank you, Dr. Suplee. The goals of today's webinar are these 4 points. First of all, we're going to talk about how we can understand why continuous quality improvement is so appealing, particularly for home visitation programs. Second, to understand what constitutes a culture of quality and what are the components. The third is to provide an overview of elements to build a culture of quality within your organization. And the fourth is to gain additional knowledge and insight into the value of quality improvement. We're going to particularly focus on the middle 2 points. In subsequent webinars, we'll be introducing specific tools and procedures in CQI. But we want to make sure that they are embedded within a strong organizational culture of quality, which is needed for them really to succeed. First, a definition, continuous quality improvement, continuously improving performance of systems through a series of metrics to enable the delivery of reliable, consistent results the first time, every time. And there are a couple of key points in this definition. First of all is systems thinking. Often in home visitation, we think very much at sort of the individual and family level. But in continuous quality improvement, we're particularly interested in the system in which we're doing our work. The other feature in this definition that's important is the metrics, the idea that we're measuring data that are important to us to do our work and to drive quality improvement. And finally, that our ultimate goal is to be able to get the very best outcomes with our families as often as possible, and CQI is a means to do that. What is appealing about CQI? Well, the first is it helps us address variability, particularly unintended variability, variability caused by the fact that we often work with populations that have unique features, or we work in geographic settings that have unique issues. Or even over time, as home visitors do their work, they may stray or drift away from what they initially learned. All of these are unintended sources of variability. Usually we don't know much about them. We know they're there, but CQI provides a way to identify variability, measure it, and actually learn from it and get better as a result. So it gives us a very useful tool that we don't otherwise have. The second thing in CQI that's important is we can generate new learning over a relatively short period of time and with small numbers. And this is appealing because often in traditional research we need large numbers and we need to wait a long time before we get the findings we're interested in. And even in program evaluations, often there's a fairly lengthy time period involved. But with CQI, we can learn things very quickly, even with just a few families or a few home visitors over a relatively short period of time that could help us improve our work. The third thing that's appealing about CQI is that we get to use data to make decisions, and it helps us so that we're not overly reliant on subjective sources of information or our perceptions or hunches or guesses, but instead data are helping us make the kind of decisions we need to make to maximize the benefits of our program. And then the fourth, and really among the most important points for home visiting programs in particular, it provides a way for us to systematically and to use data to adapt models and programs to the local conditions and some of the unique environments in which we have home visiting programs, while simultaneously retaining those essential features and core components of the models that we use that are so important to program effectiveness. Let me acknowledge at the outset that CQI can be very confusing. This is just a screenshot of a recent Google search I did on quality improvement. You can see it generated almost 3.5 million hits. I think particularly for those who are less familiar with CQI, it can be a very daunting field. Lots of jargon, lots of different tools, lots of different methods, different places to go for information. I think it's, although it's a little challenging at first, it is something that can be mastered and made to work for us in home visiting. Going along with that are the myriad graphs and tables and diagrams that we always produce in CQI because it is data-driven. These two can be somewhat challenging at first, but as you'll see, there are a number of options for us in home visiting that can be quite useful. The culture of quality, which is, of course, the primary focus of the webinar, is comprised of 6 components: attitude, transparency, data, commitment, understanding of our current culture, and a focus on outcomes. All 6 of these components work together. They support each other. They interact synergistically. And we really need all 6 to create that culture of quality within the organization that allows us to implement CQI programs to maximum effectiveness. So we need to pay attention to each of these. This quote really underscores this, and one of the things that one finds in the CQI field, there are lots of quotes, and they often really hit the nail on the head and help us understand a particular point. And this quote by Philip Crosby, I think, does that and really points out that in order to have a culture of quality, quality really needs to be part of the everyday work and not just sort of a secondary add-on. Other aspects of the component, or comments at least we can make about components of a culture of quality. First of all, we need to generate buy-in at all levels. Everyone in the organization has to be working together and seeing a shared mission rather than working individually and in silos. And as I go through these, I hope you're thinking about your home visiting organizations and how they sort of match up to some of these components. The second aspect is we need to really understand the systems in which we work. Home visiting is a very complicated process. The systems are very complicated, and understanding how our processes work, what has to happen for us to do our work is very important if we're going to actually work towards improving them. The third is that data that are collected are relevant and meaningful, and we're going to talk a little bit more about this as we move along. But the data that we collect really need to be ones that we that are meaningful to us in doing our work, meaningful to our families, and as a result, they come to be valued within the culture of quality. Of course, we have to use the data also, and that's the next point, that we actually use the data to monitor progress over time, always keeping in mind a target. So we'll have some examples of that as well. And finally, another aspect of components of a culture of quality is that we apply small tests of change. We actually test out interventions and see whether they work and improve our systems. There'll be a little bit more on this in future webinars, but just want to give you a flavor for what's involved there. This quote also exemplifies a very important point, and that is that quality is something we have to plan for. It's something we have to build in. It doesn't happen by accident. We have to be very proactive in building it into our organizations. The first component, attitude. And in the aspects of attitude, we have to have the right attitude to be able to really create that culture of quality. The first is that everyone strives to reach predetermined and ambitious targets, that we really have a sense of how well we can do, that we're not just doing the best we can, but we really have a very clear sense of what kinds of outcomes we want to achieve, both with individual families but also our organizations. The second part of attitude is that we recognize opportunities for learning. There are lots of opportunities to identify where things are going well and where they're not going well, and we recognize these as ways to sort of generate ideas that we can then build into continuous quality improvement efforts. The third part of attitude is we value data. We see data as essential to our day-to-day work, and we recognize that we can't do our work without good, meaningful, helpful data. And finally, of course, moving towards the highest quality that we can get to is just the right thing to do. Regarding opportunities, failure is actually an opportunity. Failure is often something we don't like to talk a lot about and we don't like to perhaps bring to the fore, but there's actually evidence that failure presents great opportunities for learning. This is from an article on this slide that comes from industry, and of course CQI actually was developed, as I'm sure most, if not everyone knows, in manufacturing and industry. And although this article is about something that is pretty far removed from home visiting, there is an important lesson in it. And in this study, the authors found that organizations that were on the lookout for identifying failure, had cultures where people could talk about failure, it wasn't stigmatized, people weren't penalized, actually learned a lot more from understanding what went wrong than when they focused on all the things that went right. And that leads us to the second part, the second component, and that is transparency. That is, there is openness in terms of our practices and the methods that we use. We share them with each other. Particularly important, we share results and outcomes. So everyone knows how our families are doing. All home visitors know how other home visitors are doing. Different sites within perhaps a larger umbrella home visiting organization know how each of the sites is doing. This kind of transparency is essential if we're really going to have a culture of quality and be able to implement a CQI program. Within this, we recognize individual contributions. We don't just put everyone together into one sort of lump statistic, but rather we really call out people who are doing particularly well or achieving outcomes that we think are particularly laudatory so that everyone knows. Open communication is important. People need to feel that they can speak up, that they can share information, and also that they can critically scrutinize both their own work but also the work of others. As long as that's done in an open and transparent way, it should be non-threatening and really create a nice foundation for pursuing quality. Transparency also allows us to save time and increase efficiency because we're not reinventing the wheel. It may be that someone has figured out a way to do an important aspect of implementing a home visiting curriculum, and by sharing that information and having forums in which to do that, they can really spread best practices around without reinventing the wheel. Finally, I want to acknowledge that this is challenging for many organizations. This is, in many ways, this is the hardest thing in building a culture of quality. For some organizations, it's going to be a difficult process, but it will ultimately be a worthwhile one. Just an example of the kinds of sort of reports, a hypothetical one here, of course, sort of showing comparisons. These could be comparisons between families, between home visitors, between sites, between organizations. Again, that kind of sort of sharing of performance is an essential feature of transparency. Another component, data are valued. First of all, of course, we need a data collection infrastructure. We need some way to collect the data, put the data on a computer, have an MIS system that allows us to manage the data, produce reports. So we need to have one of those. We also need to have reporting metrics that are meaningful, so data that really resonate with us and reflect what's important to us and to our families in our day-to-day work. So these are not imposed from above, but can be generated within the organization to be meaningful to actual clinical practice. And of course, they're not only relevant, but they need to be accurate and important. They need to be important to our families and important to home visitors. As we collect these data, we of course produce reports. It's important that these reports be timely and recent. If we get a report that tells us how we did last year, that's not going to be very helpful to us necessarily in terms of, well, what am I going to do with my families this week? We need much shorter time periods between reports for them really to be useful in continuous quality improvement. These reports also show our performance relative to some target, and it's essential that targets always be present on our reports so that we know what we're striving to reach. I'll show you an example of that in a few slides. Ideally, reports also show changes over time so we can see whether we're moving in the right direction or the wrong direction and sort of catch issues and problems before they become big so that we can do something about them. And finally, reports also break out into smaller units. We don't just produce reports of the whole organization. We have reports that may just be on a few families or an individual home visitor or an individual site. There also needs, in a culture of quality, to be there needs to be organizational commitment. That is, all members are really committed towards achieving the highest quality service and embrace the CQI program. If some endorse it and some don't, it's not going to work very well, particularly if those who are not supporting it are those in senior leadership. Everyone really has to be on board, and as a result, everyone also needs to be trained. This isn't something just for home visitors. On the contrary, everyone in the organization needs to be familiar with how to use CQI methods. Improvement is guided by a team approach and accountability. That is, this isn't something that a single person does. Really, our improvement needs to be, our improvement efforts need to come out of a team where everyone has a role on the team. And the team holds themselves and each other accountable for doing what needs to be done to really drive improvement. Data are also readily accessible. We can get to them when we need them. They're not, again, there aren't long delays between when we need them and when they're available. And part of organizational commitment is also a preoccupation with curiosity. How do things work? Why are they working? Why are these things over here not working? That constant curiosity leads organizations in the direction of successfully implementing continuous quality improvement. In order to have a culture of quality, we need to have an understanding of the current culture of our organizations. Do we have a mission, vision, and values that actually support a culture of quality? Or is there tension and clashes that we need to address. We need to have a real sense of where we are today and where we want to be. What kinds of outcomes do we want to get? What kind of organization do we want to be in 1, 2, 5 years from now? We need forums where we can communicate with each other in a consistent way and frequently so that we can, again, share information and operate effectively our CQI program. There needs to be very clear lines of accountability. Who is supposed to do what, and what is expected from performance. And finally, we need to have a real understanding of our processes and procedures, which indeed may be different from site to site, depending on some of the unique geographic differences or cultural differences between the populations that we work with. We're also outcomes oriented. We're very much focused on outcomes. Outcomes need to be clearly articulated and understood. That is, what exactly are we trying to achieve? This is particularly important in home visiting, where we're often trying to achieve a lot of different outcomes. And they can all get lost if we're not really clear about what it is we're trying to do. Outcomes are measured against an established target. We really have a sense of what we want the outcomes to be, so we can know, are we near that target? Have we reached that target or not? All of our process measures need to be tied to outcomes. If we're interested in increasing the number of home visits, for example, we have to ask, well, what should we expect to see if we increase the number of home visits? Perhaps more children developmentally on track, more children with medical homes, whatever it is we think is going to happen. We don't want to try to change process measures just for the sake of changing them. We always want to keep our eye on outcomes. And again, a reminder of the need to have that deep understanding of our systems, our processes, and procedures. What are the steps that we follow to do our work, which are often complicated and contain a number of areas where things can go wrong. If we don't have a deep understanding, we can't monitor them and improve them and change them. Finally, performance is reported frequently. We know how we're doing, we're told how we're doing, and we're told often, so that we can really keep an eye on it, not just, a report at the end of the year, but something more frequent than that. I'm going to show some examples of how data are presented in a way that's consistent with a culture of quality. Again, just to sort of bring to life some of the principles that we've talked about. This is an example of a trend chart, and actually this particular chart has a lot of information, and it's really a very simple chart, but if you look at it very closely, you can see all of the things it has. First of all, up here we have a graph on top, so for those who are very visually focused, we've got a nice graph. If you like tables, I'm going to try to make another one here. There we go. If you like tables, there's a table on the bottom. So there are both ways of presenting it. You can see that we're presenting data by, in this hypothetical example, by quarters. So we've got 4 quarters, and then all 4 quarters are rolled up, and in the far right-hand side, we have an annual total. So we can see change over time. There is our target. So we said we were always going to have some sort of target on these kinds of reports, and the green hashed line is a target. We can also see that we've got 2 lines here. One is for the organization as a whole, and the other is for an agency within the organization. So an agency can see how they're doing relative to the organization as a whole, or a site, with how they're doing relative to the larger entity, but they can also see how they're doing relative to targets. And we can see change. We can see from quarter 3 to quarter 4, even though the organization as a whole got a little better and closer to the target, the agency actually slipped a bit, and might lead us to ask the question, what happened? How can we learn from that and figure out what was going on? So you can see there's a great deal of information in this otherwise fairly simple diagram. Here's another example. This is in a tabular form, this also shows different kinds of objectives that the organization is trying to achieve. This is over an annual basis, so you can see that in this instance it's annual. We've got our targets, so we like to see that, so we can always see what it is we're striving to do, and then we would fill in the two columns to the right the number and the percentage in this example. This is another example of how to display information. This we call a red-green chart. It shows a series of sort of indicators, things that we're interested in, that we're measuring and we're interested in achieving our targets. There's our targets in this column. We've got sites on top, and we can see the green tells us that that target has been reached for that indicator. Red tells us that it has not been reached. And at a glance, you can see some targets. Make this work. There we go. Some targets in which everyone's sort of struggling with in this hypothetical example, well, baby visits. Or we can see perhaps some agencies that are either not doing so well. Agency B is mostly red. Something's probably going on there that we would want to understand. Agency D, however, is pretty consistently green, and something's probably going on there that we would understand. So this particular example doesn't show us change over time, but it does give us a great deal of information that one gets visually very quickly, and it's very meaningful and helps us move ahead. In this final data example, we've got bar graphs, and we've got 2 years, 2007, 2008. This is another hypothetical example. Sites here on the bottom, 6 different sites. We've got our target, and then we can see, again, changes. Here's an agency that's done pretty well in both years. Here's an agency that did well in the first year but is slipping. That tells us something, or may tell us something. We have to dig deeper. Agency 4 here wasn't doing so well in 2007, did much better in 2008. Something is going on. So you can see we can learn a lot from this too, or at least it brings up some questions that we want to sort of dig deeper on. So what I encourage you to do is to think about your own organization and think of this sort of organizational culture of quality checklist and ask whether your organization has these features and whether it is prepared to implement a successful CQI program. Now I'm going to turn it over to Kathy Hatfield and Rebecca Kelly, who will give sort of a real-life example of their experience at Child and Family Tennessee.
Thank you, Dr. Ammerman. Good afternoon, everyone. As he said, I'm Kathy Hatfield, and I'm the Director of Grants Management for Child and Family Tennessee. And with me is Rebecca Kelly, our Director of Client Operations. And we were asked to come and tell our story related to continuous improvement. And you'll see that a lot of what we've gone through over what we're going to share really kind of highlights some of the points that Dr. Ammerman pointed out. So to lay a brief foundation, we're a private nonprofit agency in East Tennessee that has 35-plus family-centered safety net programs. We began in 1929. The community saw that it had a problem with unwed mothers and their babies, and our agency was the start of the community solution. And over the 81 years, we've grown, but we've pretty much stayed true to our mission. So the big picture we want to share is the transition in culture that we've gone through by putting research into practice. And this slide shows our progression and growth over the last several years, pretty much from, in particular, from what I consider the tipping point. And we weren't necessarily aware of where it would lead us, although I do think it's important to point out that we were very intentional in terms of using evidence-based models, being proactive about data and growing and spreading and trying to bridge the gap between data and practice. And so ultimately, it led us to a shift internally where we have a real valuing of continuing improvement and use of data and evidence-based models in our practice that is throughout all levels of our organization, and we're really excited to find out where we're going to end up in 5 years. To start with our story, I'm going to start from the beginning, which was our Great Starts program, and I'm going to start on this chart on the left-hand side. And our journey started with realizing at the beginning of this program and through the first part of it that we really had a gap between our data and what was happening within the program in practice, and that we needed more internal data and access to more internal data. It helped us embrace the need for evidence-based models and practices, and to lead to increased quality of services. This was a Children's Bureau grant. It started in 1990. It's actually a program that we've been able to sustain now since that time. It's almost 20 years old. And it was an evidence-based practice for substance abuse and child development services. And the way that evaluation was handled at that time, we had an external third-party evaluation system. And the system was set up where every 6 months we would get reports, and every year we would have an annual review. And what we realized was even though we experienced improved capacity, there was a gap between that data that we received and getting it into program operations, and the way that it was being used for quality improvement for our situation, it made it limited. But it did prepare us for the next step in our development, which really was bridging the gap with our second federal grant, and that was the tipping point for where we've grown and the lessons learned. So that's really where we learned that what you think is not always what it is, and that there was a real importance for data. We learned that having ready access, we began to appreciate more what you could do with the data and what we could learn. It's during this project that our staff actually started using the data with clients. For example, we would do, say, a small depression scale screening, and then the staff would take that in when they were meeting with the client and use that as a jumping off point for a real dialogue with the client about where they wanted to go and what it might mean and that kind of thing. We also were surprised by some of the data that we found. That this particular project, the staff thought for sure that they were dealing with issues of substance abuse and domestic violence, and certainly they did see that, but we were able to show them with the data that overwhelmingly what they were dealing with was mental illness, emotional difficulties, and behavioral problems in both the adults and children that they were seeing. And so the staff started to see more of a practical value for what we could do with the data. And we also experienced the commitment that was needed. There was an intensive cross-site evaluation that was attached to this particular project that honestly was sometimes painful, but we learned so much. And our leadership really started getting involved, not only within the agency, but also on a federal level. And from this point, we started taking what we had learned over the process so far and spreading evidence-based practices into some of our other 33 programs within the agency beyond Great Starts and Bridging the Gap. This was a 2004 federal child abuse and neglect replication. There were significant cross-site activities, as I mentioned. We actually started a process of bringing more of our data closer to us in-house. We started building in resources for evaluation and for continuous quality improvement as we developed projects, building them into our budget and planning for them as an input with our logic models. And as I stated a minute ago, we began using them to spread it into our other agency programs and started to realize how much more we could do if we restructured things a little bit differently and use it in our practice. So that led to our next stage of growth, which was our New Beginnings program, which really built some capacity in our organization. And it's really where we learned how data could help us to build some language in terms of bridging between grants and operations and actually within operations. And we found that we could develop some data and systems for reporting in a common language so that everybody had that. And we established a structured grants management unit within our agency that we brought all of our data in-house. We manage all of it that way. We still have an external third-party evaluator who serves to provide us with consultation and guidance, but it really gave us the flexibility that we felt that we needed, and that was based on our assessment through the last few years in doing those other programs. And we really started getting proactive about adopting an evidence-based culture and spreading it into all 35 of our programs, and that was from simple to complex. And so to get into some of our learnings there, Rebecca's going to talk to you about an example we had in terms of vocabulary gaps.
Well, thank you, Kathy, and I do think you're going to find this as a great case example of building components of quality into a culture. Our operations staff and our grant staff met with the purpose of looking at how to quantify the stage of change model into a residential program to be the behavior modification. As we sat down to begin this process, there was an obvious disconnect between operations at our grants department and also within our operations. The language and the objectivity within operations, such as what it meant to engage in treatment, what it meant to take risks, all of the aspects that would quantify exiting stage 1 and entering stage 2 were subjective and tailored to a paradigm of the individual therapist and or supervisor and their experiences. This was very eye-opening for everyone there. The disconnect between grants and operations was large as well. Grants would ask how the stages of change were quantified, and operations staff would give the client guide for the grants department to read, which outlined the stages of change but lacked objectivity and measurement. Grants and operations were also operating from different paradigms. Thus, they had a specific language, culture, and experience that the other was not privy to. We had to learn from each other's world and then bridge our gap. From our conversations, we gained the ability to understand and appreciate the need for each other. Our common ground was to collaborate for the sole purpose of providing the best quality care to people who needed it the most. We were able to develop a tool that helps everyone agree, see, communicate, observe, and measure the stages of change. This could not have happened without both paradigms being present and willing. Thank you, Kathy.
Thanks, Rebecca. So really, it helped us overcome some of the barriers that sometimes happens and does happen. It happened to us in terms of taking data and putting it into practice. And so the strategies that we have used have really helped us with some of that in terms of what Rebecca was saying in terms of meetings where we hash through when we run into vocabulary gaps, resistance, and the varied intensity and complexity. Not all of our programs are federal initiatives like the 4 examples that we're talking about today, and so we've taken a strategy of meeting the programs where they are. For example, we have a small prevention program that's in the local schools, and we began evaluation and data collection at that point with just getting feedback, surveys, self-report surveys from the teachers in terms of, is this working for your students? And so we tailor the evaluation from simple to complex depending on the budget and the situation and where that staff is, and then we build from there. And the other thing that we do to help with some of these barriers like resistance and the size and that kind of thing is we incorporated some folks within our evaluation unit. They certainly know evaluation and research and data, but they also had some practical program experience, which has helped us in the course of working this through our systems and our different programs. And the other thing we do is we've included all players within the conversation. So when we were hashing through the example that Rebecca was talking about, I mean, we had everybody there, and we take seriously what the program people feel like that they need in terms of whether the data is user-friendly, whether it's telling them what they needs it to say, how long something is taking, or if the clients are running into barriers as they're, working through what it is we need for the data. So that really has led us to our latest shift, which is our Child and Family Nurse Family Partnership, which is our evidence-based home visiting program. And the lessons we've learned from that, where we really have got an ongoing consultative process between the partners and our use of data, between the program people and use of data in practice. And it's still a work in progress over time. We really view this whole thing as a process, but we're working with programs to spread evidence base and the use of data for continuous improvement through our whole agency, so that we don't compromise fidelity, and so that now we're actually also working and have grown where we're working to address social and system change efforts in the community and the state. And the things that we've learned from that are how much deeper understanding we have of the process of collecting data and how meaningful it can be in terms of research to practice. We've learned how difficult it is, but that it really is worthwhile, and that evaluation doesn't have to be complex, and so that our smallest programs to our largest programs, our evaluation and the way we collect data and the way we try to return it to the programs is all tailored towards where they are in meeting that program where it is. And so you can see that the whole progression here, where with each process and each program, the lessons that we learned and the growth that we feel like that we got out of it in terms of our identifying lessons and gaps, and have intentionally pushed ourselves to use data and what we learned to improve our programs and our agency. And it's actually really given us some very clear advantages in terms of a fairly short period of time. We have a sustainable system. We have a sustainable system in terms of collecting our data, setting up our data with our grants management unit. We have a sustainable system in terms of working together with grants and the programs together, and so that we really have a systematic way that over time and through the process we're working to get evidence-based services, and the way we use data and bridge the gap with practice across the whole agency. We're using it and have benefited from the common language, like in the example that Rebecca gave in terms of leading to cultural shifts. We've really seen our funders recognize and have a favorable view of the accountability that this process has been given through our continuous quality improvement system. And we have data readily available, and we can tailor it toward whatever audience it is that needs it and try to put it in a format that is relevant and meaningful for the people that we're trying to tailor it to. And ultimately, and in my view, I mean, really what we all in this field are about is changing lives. It's provided us for a platform for understanding our clients differently. And so now I'm going to turn things back over to Dr. Ammerman.
Thank you. Just some 2 slides here that provide some selected resources and readings. Here are, and this is very much selected. There is an enormous amount of information on CQI, as we mentioned at the beginning. But here are some very interesting and helpful websites that some of which talk directly about home visiting, some not so much, but close. And they should provide some useful background information as well as tools that can be used and thought about for home visiting programs. And then on this slide, some selected readings as well, some about home visiting in particular, others more broadly focused, but also good starting points for thinking about not just culture of quality, but other aspects of CQI and how they can be applied. So let me turn it over to Jill, finally.
Well, thank you, Bob, Kathy, and Rebecca. You've provided us with a wealth of information to help home visiting programs move forward with creating a culture of quality. As Lauren mentioned in the beginning of the webinar, this is the first of a series of webinars that we'll be doing on a variety of topics such as data systems, tracking and reporting on benchmarks, and so on, as well as providing individual technical assistance around evaluation to the maternal, infant, and early childhood home visiting grantees, as well as coordinating peer learning opportunities. Thank you to all that contributed to the content covered during this webinar, including staff at JBA, MDRC, Cincinnati Children's Hospital Medical Center, and Every Child Succeeds, and Abe Wondersman from the University of South Carolina, as well as ACF and HRSA staff. So at this point, we're going to turn to the questions that we have received through the question and answer panel. And as a reminder, if you would like to submit a question, you can do so in the bottom right-hand corner of your screen. So we've received a number of questions, so if we don't get to your answer today, we will respond to you offline. We've gotten several questions about whether the slides will be available after the webinar, and the answer is yes. We will send a link to the archived webinar to all the individuals who registered for this webinar. The next question is, if we want to build a culture of quality into our organization, what are the first steps that we should tackle?
That's a great question. I think the first thing to do would be to look at the slide about understanding one's current culture. Having a good understanding of how things are set up now, again, sort of the lines of communication, the lines of accountability, whether the mission, vision, et cetera, are facilitators or barriers would be the sort of first place to start. The second thing would be to look at that slide towards the end. I think I can manipulate this. I can. I hope it's moving. Well, it's probably going to just move. Well, okay. I'm never going to find it. To look at the slide that actually had the checklist and to go through that in a team way. I mean, creating a team within your organization to really look in depth at how the organization can begin to move to the valuing of data, transparency, attitude, et cetera. It's a journey, and it's not going to happen immediately, but if it's done in a very planful and comprehensive way, a lot of progress can be made over a very short period of time.
Great, thanks. Another question was whether you can describe what this looks like on the ground at one or both of your programs, so how this process works locally.
Well, I will go first. There are in several of our publications descriptions of how this works, at least in our organization. Otherwise, that's sort of hard to do within the context of a webinar. That may be something we'll want to do offline. But maybe Kathy and Rebecca can add to that.
Well, this is Kathy. I can tell you that what we generally do is build, based on our logic model, we try to have this as a part of that and plan for it in that way, but that it is always, to my mind, a work in progress, and so it depends on what we kind of work backwards from the outcomes that we want to see and what makes sense and what the resources are within that particular program. And then look at, as you mentioned, what the current situation is and where we'd like to start in terms of strengthening, and then we take one small step and build from that, if that makes any sense.
Okay, great.
Yeah.
So the next question is, how do you see this applying on a state level where there isn't necessarily the funding carrot to encourage participation?
Well, this is Rebecca, and that's a great question. One of the things that the data allows for is the ability to look at cost effectiveness and cost savings. And usually when you put it in that type of terminology, somewhere someone begins to take interest. So what I'd recommend is to begin the data process and the quality improvement and use it to look at cost effectiveness and how you can provide a service that is more cost effective versus what's currently happening.
I think also I can weigh in that CQI needs to be built into everything that's done. And there are actually unique opportunities at the state level to create programs in which CQI isn't, again, off to the side or a secondary kind of focus, but is integral to doing the day-to-day work. And if it is built in that seamless way, it becomes quite integrated and quite supportable and sustainable over time. And I think the example that Kathy and Rebecca gave really exemplified that point of once they created the system and the infrastructure and had created the culture, it becomes much easier to sustain over time.
Okay, thank you. The next question is whether you can talk about utilizing CQI on a community level when communities might be using one or more evidence-based home visiting models.
Sure, CQI can certainly have a community level. Ultimately, CQI has to sort of be embedded in the day-to-day work of sort of frontline practitioners, but there are a number of examples of doing this at the community level. And of course, the first thing is to be collecting the important data, having an infrastructure for collecting that data, having that data available, being able to report back to the community how the community is doing in these important areas, being able to report those data in a timely fashion, and being able to look at change over time. Once you have that system in place, the actual sort of quality work then really begins in terms of the data may tell you where to focus your efforts. It may tell you parts of your community that are having more difficulties than other parts where you should be really concentrating your resources and your efforts. And within that context, you can not only have multiple evidence-based home visiting programs, but you can have multiple programs devoted to children, families, and strengthening communities. There's really no barrier to how many of those programs can be part of this sort of continuous quality improvement umbrella.
And just to add to that, an example here that we have in Knoxville, Tennessee, is that we do have several evidence-based home visiting models at work at the same time. And at the higher level, at the supervisory level, they have come together and have developed an evidence-based home visiting community collaborative in which they all meet, they discuss their QCI processes, they discuss the data, they discuss how to refer within each other, and really use each other as a support versus, just kind of keeping it an isolate cell.
Okay, and then as a follow-up question, for those communities that are using multiple home visiting programs, how do you choose what elements to collect data on across those programs, and what if those elements don't match up across models?
Okay, that's a very good question, and really one of the challenges I think in our field as we all move towards recognizing the value of data, we run into situations in which we're collecting different data, or we're measuring the same thing but using different measures, and it's difficult to sort of integrate and pull these things together. The best thing to do, again, is to sort of organize umbrella, Kathy and Rebecca mentioned collaboratives, where stakeholders in the different programs and in the community can come together and make decisions about what data are most important to them, what kind of data everyone should be collecting in a common way, what kind of data might be different from program to program. If one does that in a sort of collaborative way in which everyone has a seat at the table and you know, feels able to weigh in and offer their ideas, one can get to a point where there's a nice system of data collection. It's not essential that every piece of data be common across all programs. There may just be a few key pieces of data that everyone can collect that can really allow you to look at both the different programs, but also how the community is changing as a result of your efforts.
Okay, great. So the next question is, what does consistency look like if we are adapting home visiting programs based on client needs?
All home visiting programs allow for some adapting of the program to client needs. So that's, of course, true across all of them. All of them, however, also have sort of core elements and core features that are consistently given to everyone in one form or another. So the fact that one is doing some degree of individual tailoring to a family doesn't mean that there isn't some sort of overarching consistency in either the kind of information that's provided or the kinds of issues and challenges and problems that are worked on, or the kinds of things that we measure. So I don't see those two things in opposition. Again, I think all practitioners have to do some sort of individual molding of what they're doing to take into account individual client needs, but usually that's within the framework of some common elements.
Okay. And as a reminder, if you have questions, you can enter them in the bottom right-hand corner of your screen. And the next question is, how do we make staff feel comfortable with this process and not feel like it is a punitive process if they are not looking well?
Well, this is Kathy. I'll start with that one. I mean, part of what we did were use specific strategies to try and help with that. Where I was talking about meeting a program where it was, starting and looking at what they were using. We very much come across in conversations to staff as a support to them. How can we help them? You know, we know their goal. We accept that there is an assumption that everybody wants to do the best they can for that client, and how can we help you do that better? Some of the other strategies I mentioned that we use are to include them in the change process and in the conversations. We constant feedback and conversations with them, and we included folks with program experience within our evaluation within our evaluation unit in terms of so that we can get through those conversations and they know that we have been where they've been.
And just to add to Kathy's comment, that we made sure that we really celebrated small successes. And Kathy and I were very much on the same page of celebrating successes with the grants department, with the operations, and bringing them together to acknowledge the work that they were doing together to create a quality, a quality culture.
Yeah, I could also add and underscore home visitors need to have a seat at the table. They need to be part of the CQI efforts and the CQI teams, and to the extent that they are part of the process and part of making the decisions of what are we going to work on, how are we going to approach it, in many cases, they have the most knowledge about processes and how things actually work in practice. They're essential elements or essential contributors to the process. I also agree in celebrating the successes, particularly if things aren't going well and as a result of a series of changes, they go much better. If that is acknowledged throughout the organization and given a very prominent recognition, that really communicates to home visitors and staff that improving, getting better is very much admired and respected and appreciated within the organization. Having said that, it's very difficult to get people away from sort of gravitating towards the negative side, which is one of the reasons why I had a few slides there on the value of failure. In the one example we have of the red-green chart, there are some people, they look at that, they only see the red, they don't see the green. So it's a process of really creating an organization that values transparency and rewards improvement, regardless of where you started.
Okay. The next question is, how do you apply this model to a program that has home visiting as one component of the program?
Well, this is Kathy. I mean, the way that we have programs that I can think of that have home visiting as one aspect of it, and in terms of the continuous quality improvement process for those programs, we're still going to start with, you know, what are the basic outcomes that we're looking for, and then work back from, you know, each component, each activity, you know, what makes sense in terms of data and measurement and giving that back to the program in a way that's meaningful for them. So we don't want to isolate on one component, but it is a part of it.
Yes, CQI really provides a wonderful opportunity to integrate multiple programs. I mean, usually the problem when we have multiple programs is that they don't talk to each other very easily. They operate somewhat separately, and integrating them is a struggle. But CQI gives you an opportunity to choose some common measures, or to choose some measures that would be of interest to both components. The actual procedures of testing changes and whatnot can readily be done if there are multiple programs. But it actually, I think, can pull them together in a very nice way.
Okay, thank you. The next question is, if this process identifies variation across home visitors, for example, what's the first step in determining why this variation exists, or where to identify avenues for improvement?
Yeah, I can at least start with that, and sort of say again that in future webinars we'll be able to talk in a little more detail about some of the tools. But the first thing is to be open to all of the possible sources of that variation. It may have something to do with the population being served. It may have something to do with what the home visitor is doing. It may have something to do with something unrelated to both, but are important. So one of the first tasks when one sees this variability is to ask the question, well, what are the different forces that could both facilitate and undermine what it is we're trying to do? The flip side of that, or what are all the things that need to happen in order for us to achieve the outcomes we want to have, and then ask the question, are these things happening with, let's say, one home visitor versus another, or even a single home visitor who who might have different outcomes with one set of families versus another. This is where that sort of deep understanding comes into play. If you have a deep understanding of your processes and how these things actually work, it's quite remarkable sort of the number of sort of potential areas for both trouble and success there are. And it leads you to the next step to begin to start making changes. What if I change this one part of the procedure and don't do anything else, and then monitor it over time and see if that makes a difference? That would be a classic kind of CQI approach to beginning to ask, how can we reduce that variability and bring us closer to the targeted outcomes?
Okay, this is similar to the question about not having a punitive environment. And the question is about if you have reports that identify, like similar to your red and green chart, where there are different home visitors or sites that are not doing well in a certain area, how do we convince upper management that this is okay and that this is an actual learning opportunity instead of a reason to either get rid of a program or a staff member?
A great question, and it's a journey and it's a process, and this is one of the reasons why it's so important that everyone be trained in the organization, so everyone can go through this process and develop the appreciation for transparency and develop the appreciation for learning when things go well and when things don't go so well, and learning to recognize that if one person isn't achieving the same level of outcomes as the other person, that there may be all sorts of reasons for that, and understanding those reasons and changing them is the way to go, rather than assuming that they're due to lack of competence. I don't think there's an easy sort of fix or trick to resolving that. It's more of a comprehensive. If you can get everyone on board with the idea that CQI is the way to go, and then go through the training and the immersion, one can get to a place where the culture shifts and changes.
Okay. The next question is CQI something that we actually sign on to, or just strategies that we implement?
I'm going to try to understand that. CQI, I think, starts off with the signing on to part, and that's been the focus of this webinar in particular. After that, it's very much a series of sort of strategies and approaches. So there are specific procedures and methods that are used to drive the improvement work. But those aren't going to be successfully implemented unless a foundation has been laid in the organization that is ready to implement them to their greatest effect.
Okay, the next question. In your opinion, should CQI include basic core competencies of home visiting professionals or paraprofessionals? And if so, what are your thoughts on what some of these should be across various programs?
I'm not so sure that CQI has anything in particular to say about core competencies, even though core competencies are obviously very important to home visiting, and a very an important issue that the field has wrestled with and continues to wrestle with. If I'm understanding the question correctly, I mean, I think CQI can be implemented in all sorts of settings with all sorts of people, and I see it as independent of questions regarding what kind of core competencies should home visitors have to do their work and do it effectively.
Okay, so let's see. The next question is a series of webinars the full training? Are there other components that organizations who want to implement need to be trained on? And I believe this relates to the CQI.
Yeah. Another great question. I think that the webinars are designed to support organizations in building, creating, and implementing CQI. Having said that, it's a large field. Organizations are going to be at very different stages in terms of their ability to take these things on. I'm sure there are some home visiting organizations that already have more extensive CQI built into their work now. The webinars are not going to substitute for the additional kinds of trainings that one would need to reach the highest level of implementing CQI in their organizations. But they should provide a good foundation. This is our intent to build them in to everyone's current implementing of their programs. That's one we might also add to offline. That's probably something that we'll probably need to talk about and think about. So we might add to that answer.
Okay, thank you. The next question is, are there any suggestions on where programs can obtain the training that Professor Ammerman indicates?
That's another offline one because we are certainly trying to pull together various options to provide that kind of information, at least to get people started. Certainly the websites that we showed under the resources are a place to start looking, but there are going to be other options as well. And one of our goals is to create some sort of list, at least to get people started. And we would also encourage home visiting organizations and states to share among themselves opportunities that they identify and resources that they identify to support these efforts.
Okay, we'll move on to the next question. How can we ensure that CQI is maintained with limited resources in terms of staff, bearing in mind that home visitations keep increasing?
Well, this is Kathy. I can tell you that what we do is when we're putting a project together, I mean, that's one of the things that we look at. And so we don't want it to be burdensome. And as we went through the process, if you'll remember, when we got to it, I think it was the second stage, we actually started building some resources in as we progressed through the process. And so I don't think that data management or quality improvement needs to be complex. I think that you can start very simple if it's a small program with limited time and folks don't have the luxury of where we've gotten to in terms of being able to have, you know, a few people working with us. But, you know, when I was working in just a program, an isolated program, you know, we captured data because we wanted people to know that we were what we were doing and that we were doing the work that we thought that we were doing. And so I think you start with what resources you have available.
Yes, I agree. CQI does not have to be expensive, and much of what was described in this webinar has no real cost, with the exception of the data collection aspects and some time to put together some of the reports. Having said that, it can get quite complicated. It can get quite sophisticated. There are different levels, but it is not necessary that home visiting programs be at those highest levels, although some organizations may aspire to that over time, and that would be certainly a terrific thing to see. But organizations that are small with fewer resources can very much implement CQI and do small tests of change and all the things that we mentioned.
Okay, and before we move to the next question, I just want to remind people that we will be sending a link to the archive webinar to all members who register to participate in this webinar, so it will include the slides as well as an audio of today's webinar. So the next question is, are there any CQI self-assessment tools that have been developed that people can consider and use to help them determine where they are now, where they need to improve with respect to CQI?
As I said before, we're trying to sort of pull together a list of resources to help organizations go through this process, and we have come across several of those kinds of resources, and certainly the checklist that I presented on the culture of quality was meant to sort of serve that purpose, although that was very much focused on the culture and not the other kinds of things. So we hope in the near future to be able to provide that. So the answer is yes, there are resources. We know of some of them. I'm sure we don't know of all of them. And there are various organizations who will make those kinds of assessments also, and give advice and consultation as to what might be needed.
Okay, great. Well, I think this concludes today's webinar. Thank you, everyone, for your time and for your questions, and we look forward to the next opportunity to work with you.